Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock and senior reporter Kimberly Hackett to talk about the latest news affecting general practice. Coming up, we're talking about how untapped capacity among GP locums could help deliver hundreds of thousands of extra GP appointments every week, and what this all means in light of the current challenges sessional GPs are facing finding work. We're also discussing NHS England's evidence to the Doctors and Dentists Review Body, which is due to make recommendations on whether GP funding should be increased further this year, as well as some of the steps practices are being forced to consider to cope with the tiny 1.9% funding increase they have currently been given. We're looking at a contract deal for GPs in Northern Ireland that could be agreed by the time this podcast comes out, and we'll be discussing NHS England's decision to U-turn on funding cuts it was planning to make to NHS Practitioner Health, the specialist mental health service for doctors and NHS staff. Our good news story this week is about a practice that's won a National Small Business Award. That's all to come on this episode of Talking General Practice. First up this week, let's talk about locum GPs. So Nick, you got your calculator out this week and worked out that unused locum GP capacity could deliver more than 250,000 extra GP appointments a week in England. How did you actually come to that figure?
I love a calculator-based story, as you know. And with this one, the BMA Sessional GP Committee mentioned a figure that I thought was interesting in a letter to NHS England. The letter was basically about something we've been reporting on really heavily lately, the fact that lots of GPs are struggling to find enough work. We spoke on a podcast recently about a GP who'd decided to take a job as an Uber driver because they hadn't been able to find work in general practice. And Kimberly wrote a while back about GPs having to use food banks because they hadn't been able to find enough work. The BMA has also said that thousands of GPs are currently underemployed, meaning they can't find as much work as they want. This letter mentioned a figure that had come out of a recent BMA survey. The survey found that there was quite a large gap between the number of sessions locum GPs said they wanted and the number of sessions they were actually able to work. It said that locums wanted to work 6.34 sessions a week on average, but that they were only able to find work for 5.24 sessions a week on average. Locums want to work an extra session and a bit on average per week, according to these figures. And that got me thinking, how many locums are there and what does that mean across England as a whole in terms of untapped capacity in general practice? There really aren't any official figures about numbers of locums in England because the GP workforce data published by NHS Digital only counts what they call regular locums. They don't include sessions worked ad hoc by locum GPs. So the total number of locums you see in that data is ridiculously low. It's around 1,500 headcount GPs. But the National Association of Sessional GPs, for example, has always said that the real figure is well over 10 times that number. It's maybe closer to 20,000 now. So if you assume there are 20,000 locums out there wanting to work on average 1.1 extra sessions each a week, and that a session, according to the BMA, is 4 hours and 10 minutes, of which 3 hours maximum should be with patients. If you say appointments are 15 minutes each to fit with the BMA safe working advice, you come out with something like 250,000 extra GP appointments that could be available per week. If we said appointments were 10 minutes each, then the total's way higher still. So that may even be a conservative estimate. Anyway, the idea was just to have a stab at working out how much extra GP capacity is out there. And it really does look like there's a lot if only practices were funded to recruit doctors for those extra sessions.
Yeah, I mean, that's the key point, isn't it? We've talked a lot on the podcast about the challenges locum GPs and salary GPs are experiencing finding work, which we know is due to the financial issues practices are facing. Many of them simply can't afford to use locums at all anymore. And we'll perhaps come on to talk about that a bit later in the podcast. But could some of this untapped capacity help solve the GP shortage, do you think?
I think it could definitely help. We've talked before about the fact that the number of fully qualified full-time equivalent GPs in England has dropped significantly over the past decade or so. And with the Additional Roles Reimbursement Scheme, the ARRS, large numbers of other staff have come into the general practice workforce over the past 4 years or so. And we now have a situation where general practice is delivering more appointments than ever, but the proportion of those appointments delivered by GPs is falling. GPs themselves are delivering more appointments personally, but They're also having to oversee an exponential increase in appointments by other staff, and supervising those is a huge driver of extra pressure on GPs. If general practice could be enabled to bring in all this extra GP capacity, that would bring in a bigger group of people to the profession who are able to practice independently and take pressure off the existing GP workforce in a way that ARRS staff have not. Dr. Mark Steggles, who's the BMA Sessional GP Committee chair, says it's unconscionable that there are GPs struggling to find work when general practice is under so much pressure as it is at the moment. Obviously, the effective pay cut from the 24-25 contract imposed on the profession is moving things in the wrong direction. I also spoke to Dr. Richard Fieldhouse, the National Association of Sessional GPs chair, about all this, and he actually said he thought the real gap between the amount locums want to work and the sessions they're able to find work for could be bigger than the 1 and a bit session gap that the BMA survey found. So whatever the exact amount, he said he was convinced that there's loads of untapped GP capacity out there and that practices just need to be funded to use it. He also suggested that in addition to making things like ARRS funding available for hiring GPs, which is something the BMA's called for, the government could look at scaling back plans to massively increase GP training and medical school places and focus instead on retaining GPs we already have and making better use of them.
Kimberly, let's bring you in here. We know that the BMA is really worried about the challenges GPs are facing finding work, like Nick's described there. You wrote a story last week about what the union would like to happen now.
Yes, so we've heard from so many GP partners that persistent underfunding has led to practices being unable to employ locums and salaried GPs, and now the BMA has called on the government to urgently review this. Now, a review into this would be interesting because practices have said they need and want to employ more GPs. And on the flip side, there are many GPs out there desperate for work, but the positions are sparse. Locum roles have become so difficult to come by that many GPs are applying for salaried roles. And this has led to the BMA producing guidance to help GPs seeking permanent jobs. Now, the guidance lists several questions it thinks GPs should consider asking when looking for salaried roles. Topics include employment terms, workload and work-life balance, and what's the practice culture like. The BMA has also suggested that the guidance can be used to help assist practices in designing vacancy adverts and ensure prospective employees get the best of salaried roles.
That is really interesting, though. It could be a shift to more people seeking salary jobs, and we also know that there is a shortage of those available as well at the minute, so it's going to be interesting to see what happens over the coming weeks and months. Nick, another thing that's interesting about that is that you wrote another story this week about some research that looked at the impact GP shortages have on patients, in particular life expectancy. And it found there's some really serious implications of us not having enough GPs, didn't it?
Yeah, so we've written in the past about evidence around continuity of care. There was a study in about 2018 that said better continuity of care was linked to reduced mortality, I think. But a study published this week in the British Journal of General Practice went a bit further, and it said that how many GPs there are per 1,000 patients, funding per patient and continuity are all linked to increased life expectancy. So at a time when the fully qualified GP workforce has been eroded over the past decade or so, when the BMA says that practice funding has been eroded by about 50% over the past 15 years in real terms, and when GPs are saying it's becoming harder to maintain continuity of care in the face of these pressures and rising demand for appointments, this is evidence of just how significant the erosion of these core building blocks of general practice really is for patients. Researchers behind this study said that the evidence showed funding for general practice and GP numbers should be increased, but that there should be a particular focus on deprived areas where we know that in some cases the shortfalls in the GP workforce are even more acute.
Next up, let's talk about GP funding and the pay review process. We know that practices in England this year have been given just a 1.9% funding increase. The government has said it could review this in light of recommendations made by the Independent Doctors and Dentists Review Body, or the DDRB, on the funding increase practices should receive. Of course, the DDRB recommendations would also apply to the other three nations and so have implications for Scotland, Wales and Northern Ireland as well. We're going to come on to talk about what's happening specifically in Northern Ireland in a minute. But back in England, this is the first year the DDRB will make recommendations on GP funding since before the 5-year contract was introduced in 2019. So Nick, last week you wrote a story about NHS England's evidence to the review body. We've mentioned the DDRB pay process quite a bit on the podcast recently, but maybe before we get into what NHS England had to say, can you explain a bit about what the DDRB is and how the process works?
Yeah, sure. So the DDRB, officially the review body on doctors and dentists' remuneration, is one of a number of independent advisory organisations that produce recommendations for the government on public sector pay. The DDRB is focused just on doctors and dentists, so it's separate from the NHS pay review body that produces recommendations on pay for health service staff as a whole. And what happens each year is that all 4 UK governments, as well as organisations like the BMA, submit evidence to the DDRB, making their case on the kind of uplift to pay and funding that they believe is needed. The DDRB then considers that evidence and comes up with recommendations that it puts to government. The DDRB is meant to consider factors such as needing to recruit and retain doctors and dentists and to keep them motivated. It's also meant to consider some sort of wider factors like how the NHS can place patients at the heart of everything it does and how to achieve that. And it then balances those factors against things like the budget set by the government, departmental spending limits, and also things like the government's inflation target, for example. Once recommendations are published, the government is not actually obliged to implement the advice from the DDRB, and it has chosen to ignore its recommendations in the past on some occasions, but the government does often go with the DDRB advice. So for this year, we're expecting advice from the DDRB to come out around July, and for GPs, it could yet mean that the 1.9% uplift the government awarded for 24-25 to the GP contract changes down the line.
Yeah, so last week we saw NHS England's evidence to the review body. What did that actually have to say?
One thing that stood out from the evidence presented by NHS England was that it paints a picture of rising GP income, which isn't perhaps one that most GPs will recognise. NHS England points to evidence that between 2013-14 and 2021-22, GP partner earnings rose by 29% in real terms. It also makes the case that the uplift imposed on GPs for 2024-25, the current financial year, which as we mentioned is just 1.9%. That's a figure well below inflation that falls short of the rising costs practices will face. They made the case that that's basically all they can afford. NHS England says that within the NHS settlement, funding is available for a pay uplift of 2% for contractor GPs, which is partners, salaried GPs and other salaried practice staff, and that any rise beyond this would have to be supported by additional funding from government to avoid putting pressure on other NHS services. Another claim that stands out is that NHS England's evidence says doctors in general practice have risen by more than 10% since 2018. And that's a claim based on figures that include GP registrars. But what it doesn't make clear is the rate at which fully qualified GPs have actually fallen in that period.
Some of that evidence is quite out of date, isn't it?
It is. And I mentioned that claim NHS England makes about rising GP partner earnings is based on figures that only go up to 2021-22. So in that year, GP income was actually inflated by funding for delivering tens of millions of COVID jabs. The BMA says many practices were propped up by that extra income, which they worked an extraordinary number of additional hours to earn. And what NHS England's evidence fails to make any mention of is that in the subsequent years, GP income has dropped sharply. According to the BMA, partners' income dropped by more than 20% over the past year alone.
Do we know what GPs think about all of this, what NHS England have said? I can't imagine the BMA is very happy about it.
The BMA GP Committee Chair, Dr Katie Bramall-Stainer, told me that far from rising, as NHS England claims, GP income has been plummeting in real terms because of huge cost inflation over the past couple of years in particular. And those rising costs set against below inflation increases in funding have pushed many practices to the brink, and the 1.9% uplift threatens to make things worse again. We haven't seen the BMA evidence the DDRB yet, although we know it has been submitted. But the BMA's made clear that it's used its own survey data to present a much more up-to-date picture of the state of general practice than the one NHS England offers in its evidence. We know that the BMA asked the government during contract negotiations for an 8.7% uplift. So again, just to reiterate, that's quite different from the 1.9% uplift that was awarded. And the idea of that 8.7% uplift was to bring the profession back to the position it was at the start of the 5-year contract that began in 2019 and that ended at the beginning of this year. The BMA is likely to have repeated that in its evidence to DDRB, but also to have made the case for further restoration of funding, because it also says that over the past 15 years, GP funding has been eroded by more than 50%. As you suggested, the BMA is not impressed with the picture painted by NHS England's evidence to the review body. GP leaders say they want to work with the government and NHS England to come up with solutions to the current crisis facing general practice, but for that to work, everyone in those discussions needs to be rooted in reality. And as things stand, I think it's fair to say that the BMA is not convinced NHS England's evidence to the DDRB meets that standard.
You mentioned those claims that NHS England made about the GP workforce. That is something that the DDRB takes into account when it makes recommendations, isn't it? Because obviously pay potentially impacts on things like recruitment and retention.
Yes, as I mentioned, NHS England's advice mentions a 10% increase in doctors in general practice since 2018. And the way the government makes that claim stick is by including GP registrars, so doctors training to become GPs, in the total workforce figure it uses. GP training places have increased rapidly over the past decade or so there are a lot more doctors in general practice because of that. But the number of fully qualified GPs remains about 2,000 below the level it was at in 2015. And between September 2018 and last September, there was a drop of about 1,200 fully qualified full-time equivalent GPs. There's also a lot of evidence that we've reported on recently around GPs potentially leaving the NHS. The GMC warned last week that more than 1 in 5 GPs are likely to move abroad in the next 12 months. And we reported earlier this year that less than 2 in 5 GP registrars actually plan to work in NHS general practice when they qualify. So those figures should be ringing huge alarm bells for the DDRB as it considers the recommendations it's going to make on GP pay for the year ahead.
We've been talking about the worrying state many practices find their finances in. And we've obviously talked on the podcast quite a lot before about cuts practices might have to make to cope in the current financial climate. We actually asked GPs about this in a recent survey that we undertook last month in March. We had responses to that survey from 134 GP partners, which found that 89% of them were worried about the future financial stability of their practice. Almost 6 in 10 were considering cutting back on the services they offer patients in a bid to stay afloat. Some of that will obviously relate to cutting the number of appointments they provide. Perhaps unsurprisingly, given what we've been talking about today, almost 3/4 said they were likely to cut back on their practice's use of locums, and the same amount said they would have to reduce their own drawings, so their own take-home pay. Nearly 70% said they would not replace staff when they left, and then there was a minority of partners considering some really drastic action, with 16% saying they were thinking about handing back their contract, and the same amount saying they were considering making staff redundant. We also actually asked what steps practice had already taken in the year just gone, so leading up to the start of this financial year. And nearly 80% said they'd already cut back on their use of locums, which probably explains some of the challenges GP locums are finding getting work. And 2/3 of partners said they had been forced to reduce their own take-home pay last year, which mirrors the findings from that BMA survey that you mentioned there earlier, Nick. So it's all very depressing and actually really worrying. But I think one of the worst things about that survey was reading through some of the comments that partners included. Some of them are facing some really very challenging circumstances. One GP said their business would become unviable unless there was a further increase in funding this year. One said they were already in talks with their accountants to see if there was any way they could remain solvent over the coming year. And another said they were basically expecting to hand back their contract imminently. So I think the BMA warnings that we've talked about before, that this year's contract will lead to practice closures, well, the signs that that's already happening. And there was also some really difficult stories of GP partners reporting massive falls in their own personal income. And you have to wonder really how long practices in that position can keep going if that's the case. And obviously, ultimately, if more and more practices do close, this will have a really devastating impact on patients. Nick, we're talking about funding in England here, but we've also seen some news from Northern Ireland this week about a contract deal that's imminent, haven't we? I mean, it could well be confirmed by the time this podcast comes out. So what do we know about that?
We understand that GP leaders in Northern Ireland are really close to announcing quite a significant deal with the government around the GP contract for the year ahead. It's a landmark deal, really, because it would move QOF and funding for a significant proportion of enhanced services into core practice funding. And that's a move that GP leaders say would really simplify the contract in Northern Ireland and maybe cut back bureaucracy quite significantly. Obviously, abolishing the QOF is something that's already happened in some other parts of the UK, but notably not in England thus far. But perhaps the biggest part of the deal is that we understand there's been an agreement for the Northern Ireland government to reimburse practices for GP indemnity costs for this year. The idea is that that would be a step towards a full state-backed indemnity arrangement of the sort that's been in place in England since 2019 down the track. In England, state-backed indemnity was hailed as a really important move because GPs were paying five-figure sums in some cases each year for medical indemnity. And the BMA at the time said doctors were leaving the profession in part because these costs were spiralling out of control. Wales also has a state-backed indemnity scheme for general practice, but in Northern Ireland that hasn't happened, in part because of turmoil around the power-sharing government over recent years. The BMA says GPs in Northern Ireland have effectively been paying an extra tax compared with their counterparts elsewhere in the UK over the past few years. But the government in Northern Ireland has been back since February. And Dr. Alan Stout, who's the Northern Ireland BMA GP Committee Chair, told me that they've made real progress on contract talks. And so for this year, and the BMA is hoping to get this over the line in time for practice funding allocations at the end of April to reflect the updated contract. Although I'm told the deadline for that was that there's a cut-off point during this week, after which that won't quite happen, so it might slip over into May. So for this year, practices will receive extra funding to reimburse GPs for the cost of indemnity. And down the track, they hope to move to a state-backed indemnity scheme. But this reimbursement will already mean that GPs in Northern Ireland are now on an equal footing financially with people elsewhere in the UK when it comes to medico-legal costs. As I mentioned, the QOF also looks likely to be abolished, with funding moving into core practice funding. And there could be something like the assurance framework in Wales that came in to replace it there. I'm also told that a significant proportion of current enhanced service funding, so we don't know exactly which enhanced services will go, but a significant chunk of that is going to move into core funding. And later in the year, the understanding is that the government has agreed to implement DDRB recommendations on pay. So although there's no immediate uplift to GP pay for the current financial year, in fact, this comes on the back of a 6% uplift that was delivered at the end of the last financial year to GPs in Northern Ireland. So they have actually just had a bump. But then there's likely to be a further bump in funding based on DDRB recommendations later this year. So all in all, this looks like a real win for general practice in Northern Ireland. And ultimately, it needs one because we've heard a lot lately about practice closures, underfunding and big problems facing GPs in that part of the UK. Just to mention again, though, on the DDRB recommendations later this year, we were talking about just how bad the situation is and the impact of that 1.9% uplift for England. But just as the government in Northern Ireland has apparently agreed to implement whatever the DDRB recommends to GP pay, it seems likely to me that the government in England will move the dial to some extent, at least when that recommendation comes through from the DDRB. And I think it's inconceivable that the DDRB will recommend anything below or in line with 1.9%. It's bound to make a recommendation higher than that, in my opinion.
Well, we'll have to wait and see, won't we?
Emma, this week saw NHS England forced into a U-turn after it announced controversial plans to cut specialist mental health support for doctors and staff working in secondary care. This is all about NHS Practitioner Health. You looked at some of this. So what exactly was it that was being proposed?
Yeah, so as you say, NHS England has actually U-turned on this, and we'll come on to why that happened in a minute, but perhaps we should explain what was proposed, because I think there are things that are worth considering about this. So late last Friday, NHS Practitioner Health announced that from the start of this week, it would no longer take new registrations from secondary care doctors and NHS staff, and that instead they would be directed to alternative sources of support, including their GP, their trust's occupational health service, or their employer's assistance programme. And this was all happening, they said, because NHS England is undertaking a review into the mental health support it offers to staff to consider, and I quote, long-term sustainable options. So under the plans, NHS Practitioner Health was going to continue to support existing secondary care patients, and the service would still be available to existing and new GPs and other primary care staff who wanted to access it. But NHS Practitioner Health did say that ongoing funding for that primary care part of the service, which our listeners will be interested in, that's only been confirmed by NHS England to run up until next March. So it's not certain what's going to happen after next March for even that bit. So they have U-turned on this, but just as a bit of background about NHS Practitioner Health, this is a service that's been around for over 15 years now. It was started by London GP and former RCGP chair Professor Dame Claire Gerarda, who many listeners will probably be familiar with from her practice in London. She has a career-long interest in mental health and addiction, and in particular around mental health support for doctors. So the service was originally only available to GPs in London, and then later to GPs in some other areas where the NHS chose locally to fund it. It then expanded to cover all GPs in England in 2017 with central funding from NHS England, and that was part of the GP Forward View, if people remember that. And then it extended again to cover all NHS doctors and dentists and senior managers. And then much more recently, really since the pandemic, it's extended to cover other healthcare professionals and NHS staff as well. Separate to the work it does in England, it provides support to all regulated healthcare and social care professionals in Scotland as well. So it has many years of experience of dealing with the specific mental health challenges faced by doctors and other healthcare professionals. It's also completely anonymous in the sense that doctors can refer themselves to the service. They don't have to go via their employer or via their GP. And I think that's one of the things that doctors really value. In terms of why NHS England made this initial decision, clearly it's facing massive funding pressures, which you kind of alluded to when we talked about the DDRB evidence, and it's looking for ways to save money. I mean, it's as simple as that. Claire Gerarda, who's still an ambassador for NHS Practitioner Health, said on Twitter, or X, I suppose we should call it now, that they were simply told there's no budget. I think in part that decision was based on the fact that people working in hospitals have access to occupational health services. So I think NHS England's view was that this is where those staff can access help while it carried out its review, whereas obviously there's nothing like that in primary care, and so the service would need to remain in place for staff in general practice and primary care while they make a final decision about what to do.
They were forced into a U-turn in the end on this decision. Why did they change course?
Well, there was really a massive outcry against the decision. I mean, the BMA and the Doctors Association UK were pretty quick to put out statements about it, really angry that the service was being taken away from hospital doctors, given we know the pressure that they're under. But they also really objected to the fact that this was happening while a review was ongoing, with nothing, NHS England's made no decision about what's going to replace it and what they're going to do. And their argument, there was nothing really remotely comparable in place. But really, I think the main reason NHS England was forced to change its decision was there was just huge amounts of pressure from doctors on social media. In many ways, this really is a good news story. Huge numbers of people on Twitter post their own personal stories of how they wouldn't be a doctor now if it wasn't for NHS Practitioner Health. Many people saying the service had literally saved their life. And I don't think you can really underestimate how important this service is to doctors in particular. There was an open letter in circulation asking NHS England Chief Executive Amanda Pritchard and Health Secretary Victoria Atkins to reverse the decision. And that had 16,000 signatures from healthcare professionals by the time NHS England changed its mind. And that was in less than 3 days. Many of the people posting their support for NHS Practitioner Health were doctors from secondary care who spoke about long waits for their occupational health service, which is the alternative NHS England was proposing they make use of. Some just saying the service didn't have the same specialist knowledge, so were basically a poor substitute for what is kind of regarded as gold standard levels of care. And also, the occupational health service is not really suitable in certain situations, particularly if you're a junior doctor on rotation around several employers, or if you're someone whose problems are being caused or exacerbated by difficulties in your workplace. It's very difficult to go and seek help from a service that's effectively provided by your employer in those situations, rather than going to NHS Practitioner Health, which is completely separate. It was actually quite moving just to see how valued that service is. Someone described it as an essential health service, not just mental health support. And apparently NHS Practitioner Health has helped 32,000 doctors and healthcare professionals since it started 15 years ago. And even doctors who don't have personal experience themselves of using that service are probably pretty likely to know someone who has, I would have thought. We should also remember that NHS Practitioner Health is really very successful at helping healthcare professionals remain in work or return to work if they need some time off. And really, at the end of the day, aside from anything else, that is why it's worth spending the money on a service like this. So anyway, by late Monday this week, NHS England had backed down and it's agreed to fund the service for new and existing patients from secondary care for another year, but only, as with the primary care thing, up until March 2025.
Do we have any sense of what the future might hold? You said that funding's only guaranteed even for primary care staff until March next year. Are we likely to see cuts again at that stage, do you think?
That's the concern. NHS England is carrying out this review, which it says will ensure that all NHS staff groups have the mental health support they need. I mean, that review could well conclude that for hospital staff, their occupational health services should be sufficient. But NHS Practitioner Health will obviously be contributing to that review, and I'm sure they will be able to present some pretty good data on the success rates they have and what that means in terms of keeping staff working in the NHS, because ultimately, if it does all come down to the money, the key will be to show that it is cost effective. Funding pressures that NHS England is facing haven't gone away though. But obviously by March next year, we could have a new government in place. NHS England will potentially have a new funding settlement. So we could be in a very different position to the one we're in now. But I think any attempts to scale back the service NHS Practitioner Health provides would be met by a similar outcry that we saw over the weekend into the start of this week. And obviously NHS England will be very aware that that's the reaction they're likely to get if they make this decision again. Just a quick note on all of this, if anyone is interested in a bit more detail on how that service works, I would really recommend listening to a podcast episode from our archive. It's back from September 2022, so quite a long time ago now, but it is all still really relevant. It's an interview I did with NHS Practitioner Health's medical director, Dr. Helen Garr, where she talks about how the service supports its patients. And she also has loads of practical advice on what to do if you're experiencing mental ill health or are worried about a colleague, and steps you can take to help prevent burnout. So we'll put a link to that episode in the show notes, and we'll also put a link to NHS Practitioner Health's website there as well. Finally, we've just got time for our good news story, which this week is about a practice that has won a national award for small businesses. Kimberly, this was one of your stories. Who's the practice and what exactly did they win?
Yeah, so Quayside Medical Practice in Greater Manchester won the Triumph Over Adversity Award at the 2024 Small Business Awards UK. The practice was recognised for how it handled the transition of taking over another practice's patient list. In January 2022, Quayside was given just 72 hours to decide if it wanted to become a caretaker of one of its neighbouring practices that the then CCG decided to close following a CQC inadequate rating. Quayside said yes, but its practice list jumped from roughly 6,700 patients to approximately 19,000 patients. And while Quayside did have an adequate number of staff, the practice it took on did not. It meant that Quayside has had to and still is employing more GPs, reception staff, as well as nursing staff. One of the GP partners, Dr. Mark Wilshire, told me that in the first few months there was some verbal abuse from patients, and at one point he was supervising 6 GP registrars. But the good news is that 2 of those are planning on staying at the practice when they qualify. He also said that he entered the practice so that the staff who worked lots of overtime when the takeover took place were recognised for their work. He said everyone was pleased when they won the award and to have that external recognition.
Yeah, that's really great news. That's a lovely story. Well, that's it for this week. Thanks for listening, and thanks so much to Kimberly and Nick. If you're enjoying the podcast, please do think about giving us a rating or leaving a review. It really does help us out. I'll be back next week when I'm talking to Jake Beach from the Health Foundation think tank about a recent report it produced on access to general practice and taking a different approach to how we think about improving access. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.